Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome to the Low Carb MD podcast. Tro, man, I'm really excited about this one. It's good to see you, man, first of all.
Yeah, absolutely. I'm happy to be here. This is going to be an exciting one.
And we have a poor guest that we woke up at 5 a.m. Like she's doing this. Usually it's me on the West Coast who has to pay the penalty, but man, we got you bad this time. 5 a.m. So if you say anything silly, we'll give you a little bit of break. You know, hopefully you have some coffee going.
Let me tell you, I was excited when I was reading kind of the newer trials on ketogenic diets. I came across a study on chronic pain, and I'm looked in to see, who the first author was and, how did this trial come about? And lo and behold is Dr. Rowena Field, who is just an absolute superstar and can confirm now with an interventional trial what you and I, Brian, we've seen clinically, which is that chronic pain improves. And just to give people a little backstory, we've known since about 2019 and probably earlier, we've known for decades that nutrition is intimately related with chronic pain syndromes. And more recently, there was a clinical trial, an interventional trial showing that a low carb diet had improved knee arthritis. And now we have this amazing trial that was really spearheaded by Dr. Field, showing that chronic pain can improve with a ketogenic diet. So I got to be honest, I am like a fanboy right now. I'm like so happy to have you here. I want to hear how you got started about this, or how you got, how you've, kind of came to this, and I want to hear all about it.
Oh, thank you for that. I guess, my journey into being specializing in chronic pain is sort of a bit similar to a lot of our journeys with nutrition science, in that, we have our own problem and then we sort of look to our own field to deal with that problem, and it fails dismally. And so I got interested in chronic pain because I had chronic pain myself, chronic back pain, and I at the time went to all the cool kids in physio land to try and get somebody to help me with this back pain, and nothing seemed to work. And all the things and all the advice that I was giving to clients about what they should be doing to fix their back pain didn't work for me. And I started to get this real, idea that there was something unique about me, or some sort of unicorn, and there was something about my back that just couldn't be fixed like everybody else's. And ultimately I ended up in a lovely neurosurgeon's office who offered to give me a disc replacement. And at that point in time, I guess fortunate for me, I wasn't in a health fund that covered that. And so I had to go away for a year and come back again. And in that year, I had a bit of a crisis in my career and thought, this doesn't make any sense. I'm trying all these things that I think should be fixing my pain problem, and yet nothing seems to work. So either I don't have it right and I don't understand chronic pain, or I'm just really the crappiest physio out there. Mm-hmm. And it just so happened that the time I then started looking at the literature to see, well, what's the new research in chronic pain. And it just so happened that one of the leading researchers at the moment in the area was a guy that I went through uni with, and he was a real larrikin at uni. So it interested me to see what he was saying. And a lot of the stuff he was saying, he's sort of like our equivalent of a cowboy in the neuroscience space. Like we've got our cowboys in the nutrition space as well. But, he was saying a lot of things that were different to what we understood about chronic pain, and this idea that the nervous system gets sensitized and that becomes a learned response. And there's all these things that I hadn't learned at uni. And so I obviously started applying all that sort of stuff to myself, and made a huge difference to my chronic pain problem, to the point where I have no back pain now. So that's why I started working in this area, because I wanted to be able to educate people about the stuff that I'd learned. And it just so happened that it sort of intersected with, my interest in diet as well. So I was, the typical kid growing up in the 80s that was always a bit overweight, and, went through the whole low fat, every diet that came through that was popular at the time, always struggling to maintain my weight. And somehow I managed upon a low carb diet, which worked for me. And so, I got interested in the physiology behind low carb and keto, and I'd, suck up all the lectures and stuff out there on low carb down under and those sort of places that talked about, all the amazing things that happen in a ketogenic diet. And I'd be hearing all this stuff about, managing inflammation and various molecules and things. And then I'd be sitting over in the pain seminars, and I'd be hearing these guys talking about, well, we're trying to target a particular molecule with a drug. And I'd be sitting there thinking, hang on, I've heard those terms before. Like, hang on a minute, we're talking about that back over in the keto space over here. You guys should really talk to each other, because you guys are over here not talking about diet at all, when diet could obviously make some sort of difference to pain outcomes. And then we've got all the people over in the keto space that are all really focused on losing weight or managing diabetes. But hang on a minute, they're also, patients that are reporting things like, oh, well, I went on a keto diet because I wanted to, lose weight or manage my diabetes. Oh, and then this shoulder pain that I've had for 9 months, this just seems to have gone away. And so there was this big disconnect between these two areas. And so I thought, this can't be right. I want to have a look and see what's, there must be some research out there. So I did a little bit of a search, and funnily enough, there was nothing at the time at all about any sort of clinical trials or anything that looking at low carbohydrate diets and their ability to make any sort of difference with chronic pain, which was then I fell down the rabbit hole of doing a PhD in that area, and ultimately did a clinical trial looking at that.
Wow, that's amazing. And where was it during your journey when you had the chronic pain? I mean, did you go down the standard, you were getting epidurals and you're getting medications and pain medications, all that, trying to get under control? And where did keto fit into that time frame there?
Yeah, well, keto sort of came a little bit after that, I guess. I learned a lot more about the new neuroscience research and how we really need to more, modulate what your brain's perception of threat versus safety is, because ultimately that's what pain is. Pain is a protective device that our brain uses to sort of slap us up the side of the head and make us take notice and fix whatever the problem is. And that works really great in an acute pain situation. But what happens with chronic pain, and I guess the analogy that I sort of use for patients is it's a little bit like a car alarm. So a car alarm is designed to go off and tell you when somebody's actually breaking in and stealing your car. And that works great with acute pain. So if you've just hurt yourself and you've just done some sort of tissue damage, that car alarm goes off to warn you and make you change what you're doing and fix the problem, essentially. But what happens with chronic pain, it's almost like that car alarm gets really sensitive. Somebody turns the sensitivity knob right up. So now that car alarm just goes off all the time. So now it's not that the car alarm's not real. The pain is very real that the person's experiencing, but it's no longer doing the job that it was designed to do. It's now going off all the time and not really giving you good information about what's actually going on with the car anymore. And so that's the sort of education that we sort of try. I'm working with what I'm doing clinically is helping people to understand, well, what we've really got to do is look at, well, why has my brain come up with that idea that protection is still required? And how do I get it to change that answer and come up with the response, oh, maybe it wasn't quite as bad as what I thought it was going to be. And that's how I sort of, I guess, fitted diet into this story a little bit, is because when we're thinking about something that's driving chronic pain from a threat and safety perspective, we get very structure focused, like it's the disc that's causing the problem, or it's that joint or that ligament, and we get very myopically looking at how can we change that structure. And the problem is it's not just about that structure anymore, it's really about the nervous system that looks after that structure. And so if we're thinking about what things are going into the brain's evaluation of am I safe or am I not safe, my argument's always been, well, hang on a minute, if this person is also overweight and pre-diabetic and their blood sugar is very poorly regulated and all the typical things that we see with people, then that's obviously going into the brain's calculation of danger in this situation as well. And I don't know what you guys see clinically, but most of the people that we work with are long-term chronic pain patients. And when they walk through the door, I've yet to see anybody walk through the door that is the spitting image of health, and all that's wrong with them is a rip-roaring, chronic back pain. No, they walk in the door and they're a bit overweight and their blood pressure's up a little bit, and who knows what their glucose is doing because nobody looks, and their diet's terrible. And so, one of the things that we looked at back at the start of my PhD was, well, if we take a group of chronic pain people and have a look at them, what do they really think about their diet and their health, and how do they think their metabolic health fits in with their pain outcomes? And it was interesting that, the majority of people thought their diet was great and thought their health was great, but they had an average of 3 comorbidities. So, we're talking about metabolically unwell people that are also, dealing with chronic pain. And so if we're looking at how can we change their brain's understanding of what's going on and whether protection is required, then diet gives us a really good, alternative lever to pull in that story that has often been overlooked up until this point. And it's something that somebody with chronic pain can actually take a little bit of ownership over and feel like they've got a little bit of control, when often they're in a chronic pain situation that they feel like they've got no control. Everything just makes it worse. None of the pain medications work. So that's sort of how, diet sort of came into this story, and it just made me really interested. And I think obviously me myself doing a low carbohydrate diet was part of the reason why I feel like, my recovery was as good as it was as well. So I really wanted to look at, let's get some actual research out there to give, health professionals some evidence to say, okay, well, no, diet, and particularly a low carbohydrate diet, is a really valid tool for pain management.
So how long did it take? Oh, go ahead, Tro. Sorry.
So I'm just, I lived a very similar story. I've lived with chronic neck and lower back pain for over 15 years. Had spinal surgery eventually 2 years ago on my neck for myelopathy, for weakness caused by, an issue in my neck. And now I have 3 massive disc bulges in my lower back. And I'll tell you, my own perception of pain has significantly changed. I used to think that, oh, it's a mechanical issue, right? This is a mechanical issue, right? It needs to be fixed. It's a surgical problem. And I've done a complete, 360. Now I recognize it's truly a multimodal approach. And if your central nervous system isn't protecting your spine, if it's not doing that, you're going to be prone to injury. I've gone down the rabbit hole of Sarno. I don't know if you're a fan of John Sarno.
No, I don't really know him.
Oh yeah, John Sarno is amazing. I highly recommend him. He talks about he actually still to this day, he published a book in 1985 called Healing Back Pain. And still to this day, it's the #1 bestseller. He passed away about 10 years ago. He talked a lot about the emotional and mental health part of dealing with chronic pain, and that it has, not that it has nothing to do, that the organic structures have nothing to do with it, but there's certainly an underlying cause. And it points to now the practice, which I'm sure you'll agree, and this is me saying 10 questions in one, the value of multimodal approaches. So can you talk about a little bit about the value of and how our field has progressed from, you have something, I need to inject it or take it out, to, hey, wait a second, maybe we should be looking at this a little bit differently?
Yeah, and I think that that's been something that's just gradually changed over the last few years. Like there's been a very big structural focus up until now, because I think, we like to be able to make sense of things as humans, and we join dots. So if you see a scan and it shows a disc bulge, you want to join those dots and say, well, that disc bulge obviously must be the thing that's causing the problem, when it's not necessarily the case, as you point out. Like you can have all sorts of things, and just because a scan doesn't look pretty doesn't mean the thing that's not pretty on the scan is the thing that's actually the driver of that chronic pain. And we know with chronic pain that the longer you get, the further and further down the track you get, the less and less it is about the original structure that was hurt, and the more it is about, an increased insensitivity in that nervous system that looks after that body part. And so it becomes, important to look not only at the structure, but the nerves that look after that structure and the environment around that. It's important to look at the spinal cord processing and what's happening at that level. And then it's important to look at the processing in the brain as well, because all of that becomes then part of that protective response that your brain evokes to look after you. And I think one of the other things when we're talking about being multimodal and having a look at, what other things can we look at in this picture is realizing that there's lots of other protective mechanisms that become part of that chronic pain response as well. Now, the pain's the thing that screams the loudest, so that's what everybody takes notice of. But there's a whole lot of other body systems that get involved too. And if we're thinking about something like the immune system, so it becomes involved in that protective response. So if you have an acute injury or, you've cut yourself, then we know what sort of immune response you get. You're used to seeing the fact that, it gets red around the cut to try and, kill any pathogens and do all that sort of stuff. But it's designed to have a big sort of quick increase in inflammation to do its job and then turn itself back off again. So part of that cycle is that inflammation turning on with enough gusto that it creates those pro-resolvins that turn it back off again at the other end. But what happens in a sustained chronic defensive response, like we see that goes along with chronic pain, is that inflammation just goes up a little notch. So it's just sitting up a little bit above where that, set or homeostatic level should be sitting for that person. So it's not enough that if you looked on a blood panel or something that have a really big inflammatory increase in one of the markers that would be suggestive of an infection or something like that. It's just this little, half-assed increase of inflammation that bubbles along. And something like that then affects the danger information coming back to the brain about what's going on in that body part. And something like that increase in inflammation, as you guys would well know, that's something that we can target really easily with something like a low carbohydrate diet, because changing how we're metabolizing carbohydrate and all that sort of stuff has this really crazy way of decreasing inflammation. So you can go and look at the person's diet and get them to do something there, and that has a good flow-on effect back to their immune system and back to the pain that they're experiencing. And there's a lot of other body systems that get involved as well. We think about, the autonomic nervous system. So we have a sympathetic response. So you get this fight and flight thing that becomes, again, a learned response, and the person's very hypervigilant and always, monitoring what's going on with my pain. Am I okay sitting like this? How am I going to go getting in out of the car? What if I have a bad day today? It's all this ruminating stuff. So bringing in that psychology side to it. And so in my practice, I work with a psychologist very closely. We see people together, and that's what she's doing is really working with people on that self-talk and what they're thinking, what they're believing about what's going on in their body and all that sort of stuff. Because what your brain thinks is going on is a huge determiner of how that actually plays out in your body. So we really need to start thinking bigger picture when we're trying to manage something like chronic pain, and it's really looking at all of the options that we've got to try and help somebody, rather than just being really focused on just the structure and let's give it a drug or let's do some surgery on it. There's so many other things that are available to people.
Can I talk a little bit about something you said? You said, sometimes it's about what the brain thinks is going on, and sometimes there's more to it than that. And one of the ways I really understood how poorly in modern medical and modern physical therapy, I guess, and modern orthopedics, we've failed chronic pain is some very clear studies that looked at, chiropractic interventions and acupuncture, right, and compared them to a traditional approach, which is go rest, take ibuprofen, put some heating pad on it, right? So, and when you get better, go see a physical therapist. And what was interesting is these studies that did chiropractic or osteopathic, and they usually compare them to a sham group, right? They'll look at a sham chiropractic or sham osteopathic, or they'll look at sham acupuncture even, where they're just sticking a toothpick in instead of, doing a, acupuncture. And what they found was, I found very interesting, in every single case, acupuncture does better than or chiropractic or osteopathic does better than the traditional approach, right? Which is, ice, heat, rest, and, ibuprofen, right? What I found interesting, and I still find interesting, and this kind of kicks back at Sarno and back at what you said, which was the brain thinking what's going on and dealing with that, is the sham acupuncture, sham chiropractic, and sham osteopathic performs as well as the actual intervention, and both have done better than whatever we're currently doing, right? So what do you say to, what do you think that means? Because I'm just curious, and I'd love to hear from you.
Yeah, and so it's interesting, isn't it? We always, put a placebo that we're comparing things to, but placebo is never nothing. Like, we're not doing, people still think that they're getting something. So just thinking that you're getting some sort of treatment is modulating or changing the way that your brain's processing what it thinks is going on. And we're seeing this a lot in the new research that's going on in the pain science area, because what we're trying to, a lot of what the research is trying to do is trying to trick the brain into coming up with a different answer. And so there's a lot of research being done out of Adelaide Uni of South Australia, I think it is at the moment, where there's a professor, Lorimer Moseley, that's doing a lot of this sort of work. And he's got a really great TED talk on YouTube if anybody wants to go and watch it. It's called Why Things Hurt. So it's a few years old now, but he's a really great storyteller. This is the guy that I said I went through uni with. And what they're doing is a lot of stuff. So they'll do a research project, like they'll have people with chronic neck pain and they'll measure how far they can actually like turn their head to the side. And then they'll put virtual reality goggles onto the person. And they'll change it so that the visual information that the person is getting is not matching up with where their neck is actually moving. So they'll make it so that as that person turns their neck, their eyes actually go further than where their neck has actually gone. And so they've set up a situation essentially where the eyes are lying to the brain and telling the brain that, hang on a minute, we've just turned way past where we can possibly turn with our sore neck. And that would increase their pain, even though they hadn't actually physically turned any further than what they were capable of doing before. And then they'd do the opposite and they'd swing it around so that instead of the eyes going too far, they'd only just turn. And so they'd turn and turn their head, and the eyes would underestimate how far they'd actually turned their neck. And they'd find that the people would actually turn their neck further without any further increase in pain. So research like that starts to get us thinking, how if we can trick the brain into thinking what's going on, it can actually come up with a different experience for that person, because the brain is basically being tricked and is thinking, okay, no, we're okay, not a problem. And so a lot of stuff that I do with clients now is that same sort of idea, but how can we actually change that threat versus safety balance that's going on for the person? What can we do to get it to come up with a different answer via, educating them or by tricking them, all sorts of things. So I'm not sure whether you've heard of like mirror box therapy and those sorts of things.
Yeah, it's fascinating. Yep.
Yeah, so that's all the same sort of idea where, you're covering up somebody. If we're talking about a hand, they might be covering up the hand with a mirror, and then you're doing the therapy with the opposite hand. But to the person's eyes that are looking at what's going on, it looks like both hands are doing it. But in that situation, because the injured hand isn't, or the hand with chronic pain isn't doing anything, well, it's not getting that danger nociceptive information going up to the brain, as the brain's going, oh, hang on a minute, that's not as bad as what it used to be. So again, it's tricking the brain into coming up with a different conclusion other than, oh, protection's required, which is what it's doing at the moment.
I've seen some interesting studies, and I'll quiet down after this, because Brian, I know, is like, oh my God, he keeps talking, where people who are injured, right, and they have an injury, let's say to their right. I have a myelopathy in my right tricep. You can probably see that the one tricep is smaller than the other. Maybe you can, maybe you can't. And there's some very interesting data that training the contralateral side will maintain more muscle, right, on the injured side. So there's clearly more to this than I think we are prepared to understand or prepared to admit. So have you seen that data?
Yeah. And so we sort of, I guess, use a concept like that in how we treat patients. So if I've got somebody, for example, that's got chronic back pain and they can't bend over and touch their toes, even thinking about doing that would, set them into a spin. And if I as a physio said, okay, well, you just need to improve your lumbar range of movement, we need to just get you practicing that, you need to bend over and touch your toes, and I made them do that anyway, all that's going to do is set off those alarm bells and that car alarm and just build a bigger and better car alarm, and you're just reinforcing that protective response. However, if I do something like say, okay, instead of you actually physically doing that, what I'm going to do is I'm going to get you to watch somebody else actually bending over and touching their toes. Because what my brain does when I'm watching somebody else bend over and touch their toes is it sort of projects me into the image for me to understand what that person's doing. So the way my brain makes sense of the world around me is it sort of projects me into what's going on. And so it's like the mirror neuron idea. And so that if you watch somebody else doing that task, your brain essentially borrows some of the circuitry that would be involved in you actually physically doing the task and gives a little bit of a trial run to help you understand what's going on. So that's the neurotag. So a neurotag is just like all the bits of the brain that light up when you're doing a certain task or having an experience. So the neurotag that would be involved in you bending over and touching your toes, if you were to watch somebody doing that, the same sort of neurotag is going to turn on, but just not to the same extent as what it would if you were actually doing the task yourself. So what I can do is set somebody up watching all different sorts of YouTube clips of people, bending over and touching their toes and getting them to watch their kids watch their, touch their toes and do stuff where they're bending forward. And what that's doing, it's exposing the brain to lots and lots of little bits of similar circuitry that doesn't actually trigger that car alarm going off. And if I then take another step along the way and say, okay, now what I'm going to do is get you to sit somewhere nice and comfortable, have a nice glass of red, a cup of coffee, whatever you want to have, and I want you to shut your eyes and I want you to do some deep breathing and mindfulness and just relax yourself. And then just imagine that you're actually standing up nice and tall and then you're bending forward and touching your toes and it feels great. It's not hurting at all. Your back feels great when you're doing it. What that does is it uses a little bit more of the circuitry involved and a little bit more of the neurotag. And so what you're doing is you're sort of taking the thing that the person can't do and you're unpacking it into component parts and desensitizing it along the way back towards the thing that they want to be able to do. And if you think about it, it's not that it's not rocket science. I mean, trainers have been doing this for years. If you think about the guy who's going to go and jump over the high jump at the Olympics, he doesn't just like wander out and then just run and jump over the high jump. You see him, he gets in his place and you can see him running it through in his head a few times and he does the jump successfully in his head before he actually goes and physically does it. And what he's doing essentially is priming the circuitry that's going to be involved in physically doing that task, is giving the motor planning a little bit of a trial run first before he goes and does it. And so we're doing the same thing now with chronic pain. We're taking that thing that person can't do and we're giving it a little bit of a trial run in a smaller version just to desensitize it and get used to it. So the brain's essentially amassing evidence that, okay, no, I'm safe doing that. I can do that little part of it. That's okay. That's okay. And then you sneak back towards the thing that they can't do. And so if bending over and touching their toes was the thing that we were working back towards, you do that as a process and then get back to them pulling down the actual physical thing that they're doing. So instead of then saying, okay, well, now just bend over and touch your toes. So no, what we might do is get you sitting in a chair and just get you starting to, slump your chest down and letting your back just relax down into flexion a little bit and coming back up. And again, you're just sneaking in. So we're sort of doing this process where we're trying to sort of sneak in underneath the radar of that car alarm in a way that your brain sort of doesn't notice what's going on and giving it enough evidence that we're okay, we're safe to do this. We don't need to turn on the protection mechanisms when we do it. So that's sort of, there's all this processing in our brain that's involved in what we're doing that we really need to harness and use some of that stuff. And like you were saying, Trey, the idea that, you can train contralateral, like train the opposite arm and still get gains on the other side, because we've got this cross processing in the brain where your brain's interested in what's going on in both limbs. So there's lots of really cool stuff I think that it's going to come out in the next few years about how we can practically apply this sort of understanding.
I think even if you look at professional athletes, some of the strongest athletes, you look at them and, for their, especially the light body weights, you look at them and they don't have these overdeveloped muscles. It's not that they're very strong, but they're not like a bodybuilder type of appearance. And it's very clear to any physio or scientist in exercise therapy, but it only hit me very recently that these people have such developed central nervous system. Their central nervous system is the function. It is protecting their core. It is what's driving, right, their ability to lift. And certainly they're genetic beasts, that's another story. But their central nervous system is trained. As peripherally, their muscles are trained, yes, right? But they have highly evolved central nervous systems. There is this passenger we're all living with here, right? And, when you look at the totality of the evidence, I think what you're saying is so true. When you look at chronic pain, when you look at exercise performance, when you look at, sham acupuncture and how it works better than modern standard medicine, you have to respect that, hey, there's something here that we don't quite understand. How did you do that with diet? Because how did you, because this is all magical thinking for most people listening in, who are not exposed to this kind of body of evidence and what we're saying, right? Now I have a disc bulge, that's my problem, we sound like magical thinkers. So, and you even said it, how your colleague, your mentor was like, hey, look, a cowboy, but so how did you start to put the puzzle pieces together with diet? And can you walk me through your own, personal development in terms of academically and how you came to the point to run really what I consider a very seminal trial, very important trial, clinical trial. Can you walk us through that?
Yeah, so I guess one of the things when you're sort of doing a dietary trial is I think you've got to have some sort of biological plausibility as to why you're actually doing that intervention. How's that actually going to impact on the nervous system? And that was one of the things that we noticed when we did a big systematic review that looked at all of the different dietary trials that had been done specifically for chronic pain to see what sort of was out there. And the upshot of all of those, and I think there was 40 odd trials that we had found, of which there was only one low carb one, which was the knee arthritis one that you referenced before. They all, and there's a whole smattering of different things in there, everything from, vegan, vegetarian to Mediterranean, elimination diets, all different sorts of things. But I think, one of the things that was lacking in that literature was, well, they just seemed to just randomly pick whatever the researchers' favorite diet was, and that's what they did with these people. And when you looked at the totality of the evidence, then it seemed like any diet gave you a bit of a benefit. So we did a meta-analysis of all the studies that were appropriate, and it showed, a small positive effect for diet, and that sort of didn't really matter what sort of diet it was or what sort of pain syndrome it was. Any sort of diet seemed to help, which sort of made us scratch our heads a little bit and think, okay, what's going on here? And it's probably more to do with the quality of the diet and those sorts of things. And I thought, well, I don't want to be one of these researchers who just says, well, okay, well, my favorite diet, my bias is low carb diets. That's just what I'm going to do. I mean, there needs to be some sort of plausible physiology that you're actually changing, or what are you doing when you're doing this diet? How can it plausibly impact on what's going on with this person with chronic pain, which was sort of where we then went with my PhD, was doing the background studies to develop that idea. So we did, after we'd done that systematic analysis, we did two other really large scoping review. So the first one was looking at all of the preclinical animal studies that used a ketogenic diet that reported some sort of nervous system outcome. So I wanted to show that, okay, here's the mechanistic reasons why this might be a valid diet to use. And so, we found like 170 odd studies, and we set fairly clear parameters about how long the diet had to be and all that sort of stuff. And there were 14, I think, really quite broad sort of themes around the nervous system that developed from that, things from, how it changes, the energetics and metabolism of the cells, what sort of changes there were in cortical excitability in the brain, how it regulated epigenetics. There's a whole heap of different things in there. And so we could sort of say from the preclinical trials, okay, well, there's some reasons why we should do this, even though these haven't then been sort of transposed into actual human trials yet. There's a lot of mechanistic reasons why we should do this. So we did that, and then we did the second big scoping review that then actually looked at all of the adult studies that have been done using a low carbohydrate diet. And one of the reasons that I did that trial, that review, was to, I guess, silence the critics and say, okay, well, there's no research out there in humans anyway. It's probably dangerous, all the typical things that we see that come up in the criticisms of keto diets. And so we looked at all of the human trials that were longer than 2 weeks, that were less than 130 grams of carbohydrate per day. And in the results, we separated it into 130 and below 50, so that we're talking about low carb and ketogenic diets. And there's 846 human trials. So to say that there's no research in the area is a bit silly, because there's quite a lot of human research out there. And
Can I ask you, I'm sorry.
Yeah.
So somebody said to you along the way as you're getting IRB approval, or this is dangerous, right? It sounds like that happened, or did you just, preemptively decide to do that diligence?
Well, a little bit of both. Like you see that criticisms are around the, the forums and things like that, when you're the keto haters out there are going to say that sort of stuff. But also in one of my earlier reviews within my PhD, one of the reviewers was a little bit critical about stuff, and thought, okay, I'm going to preview this and not dangerous. In the actual review, I said, well, I've been keto for 3 years and I'm not dead yet, but that's probably wasn't the right response to have to that. So I thought, okay, so I need to show that, there is a breadth of research out there, and we're not just killing people left, right, and centre. And so that review, I then went, those 800 odd studies that we found, I then went and had a look at, okay, which ones actually report neurological outcomes and which ones report any sort of outcome related to inflammation, because they're the two things that are important if we're looking at chronic pain. Anything that's going to affect the nervous system and that inflammatory loading problem that we talked about earlier. And so there's 64 trials that report neurological outcomes in adults and 63 that report outcomes for inflammation. And with the trials that are reporting neurological outcomes, 83% showed improvement, and for the inflammatory trials, 71% showed improvement. So there's quite a bit of quite good backing evidence out there to say, okay, well, if we're going to do this trial in somebody with patients with chronic pain, then there's, we've got the animal studies there that show the mechanisms. We've got some already, human trials that have done that support what we're doing. And so here's what we think we're doing when we're doing it in people with chronic pain. So then I guess I can go through all the mechanisms and stuff of why we think that helps with chronic pain if you want me to.
Yeah, if you think that there's
I would love that. I would love that, because I have my feelings of why it happens, but I'd love to hear your perspective.
Yeah,
for
sure. So I guess when we're talking about a keto diet, we're doing a couple of things. We're reducing the dietary glucose that's going in. We may or we may not be increasing the dietary fat, depending on what you're sort of trying to achieve with that. And the other thing that we're hopefully doing is we're providing appropriate nutrients and removing anti-nutrients. So that was one of the things that we were very clear about with our trial, as well as we didn't want this to be criticised as being a junk food trial or anything like that. So we made sure this was a whole food dietary intervention, and making sure that you're actually providing appropriate, nutrients for the system that it requires. So when you reduce the dietary glucose, then obviously you switch over to fat as being the fuel source, and when that's broken down, it produces ketones, where we get the ketogenic diet name from. Now, we often focus on the ketones as being the energy source, which is what they are. They replace, glucose as the energy source for the cells. But ketones are also very powerful signaling molecules. And that's the thing that we were particularly interested in when we were thinking about this, from how is this going to affect the nervous system with somebody with chronic pain. And so there's a few different important things, I guess, that ketones signal in this system. So the first thing that's probably one of the most important is it helps to restore homeostasis and reduce sensitization within the nervous system. So if we think about how nerves function, there's got to be what we call like a dynamic range in that nerve. So we don't want it to be too excitable, otherwise it's going off all the time, and we don't want it to be too low in excitement, otherwise it's too hard to actually trigger it when you want it to fire. And so that dynamic range, or homeostatic range, needs to exist within the individual nerve, between two nerves, and also within whole networks. And one of the problems that we've got with chronic pain is that it's a problem of increased excitability or sensitization within the nervous system. And so one of the things, I guess, right back at the start that tweaked my interest in where this might go from a research perspective is if you look at the type of drugs that are used for chronic pain, there's a lot of anti-epileptic and anti-seizure drugs. And you sort of think, okay, well, hang on a minute, why are we using those drugs with chronic pain? Because chronic pain is somewhere on that spectrum of sensitivity of the nervous system. And we've already got a whole, literature base that shows how well ketogenic diets work for epilepsy. So I was sort of, tweaking to that idea, okay, hang on a minute, there's got to be common pathways in here that are related to chronic pain as well. And that's what we see now. So ketones are involved in helping to, manage that dynamic range. And there's a lot of technical things that came out of those animal studies about how this might happen. And it can be things like, it might alter the GABA to glutamate ratio. And by doing that, it's inhibiting the glutamate and how it gets uptaken into the vesicles by the transporter. Or it might just be that there's less glutamate produced and there's better resynthesis of GABA. So it just seems to change that excitability
Can I translate for the audience a little bit?
Yeah, sure, sorry.
So basically, we know that there's many seizure medications that also work on pain. Lyrica, for example, is one of them. There's some other medications that actually work on seizure, mood, and pain, and eating. Yeah, gabapentin.
Yeah, some of these. Yeah.
Certainly. Topiramate is probably the prototypic example of how ketones work. So you basically found that, hey, wait a second, if we know that there's some, link between chronic pain and how the brain's supposed to function, maybe that can give us insight into ketones. And then, one of those excitatory, I guess one of those, neuroinhibitors, you could probably explain this better than I could, but GABA and glutamate are, work on the brain in terms of exciting it and maybe calming it. So you're kind of like digging through and trying to figure out, all right, what is the mechanism here? And then at some point, somebody's like, wait a second, you should test this out in humans. So how did you get them to, drink our Kool-Aid, our low carb Kool-Aid,
I guess a lot of this stuff is still theoretical. I mean, certainly we didn't prove any of this stuff in the clinical trial that we did. That's like a way, harder experimental design.
But your study was really well done. I mean, you talked about wanting to do a fair study, and I thought it was beyond fair, on how you did your study. Can you talk a little bit of how you progressed from this digging to the?
Wait, Drew, I want to hear the rest of the mechanism. So first of all, we're decreasing the inflammation. You're decreasing the sugar. You're changing the neurotransmitters. You're changing the stimulatory versus calming. And this is what we're seeing clinically. That's why I'm so interested in what you're talking about. Any other mechanisms besides those two that have come up?
Yeah, so there's a few others. So like if we're thinking about the nervous system excitability stuff, again, there's potentials that ketones are modulating G protein receptors, and so they affect redox balance and oxidative stress and things like that. And there's also the concept that there's better ATP production. So with a ketogenic diet, so you're producing more ATP, and we often talk about that, it's a cleaner burning fuel source and all that sort of stuff, and there's more available. But one of the corollaries of that is that once that ATP is broken down and are used for energy, you're left with adenosine as the end product of that. And adenosine is also another signaling molecule which affects the nervous system, and it helps to it binds to the receptor and helps to regulate neuronal excitability as well. So there's sort of lots of weird and wonderful pathways in there that we don't know. There are things that are coming out of animal studies, obviously, but overall there's this field that ketones are sort of neuromodulatory or neuroprotective in what they're doing. But apart from just the nervous system potential effects, there's also, we know that ketones impact on the NLRP3 inflammasome. So it's sort of like the big parent body inflammatory molecule, of which there's a whole heap of lots of different inflammatory cascades that come from that molecule. And so this is a signaling molecule that can affect upstream inflammatory processes. And the drug companies would dearly love to come up with something that could do that, but we know that ketones do affect that inflammasome. We know that ketones also signal a lot around mitochondrial function, both improving their function and increasing the number of mitochondria. And they're also what we call HDAC inhibitors, or they epigenetically regulate things around other inflammatory molecules and mitochondria. So there's all these really cool things that ketones potentially do in that system. But the other thing that we've got to remember that we're also doing is that we're reducing blood glucose and glucose volatility, and that in and of itself is also mechanistically potentially improving pain. So if you think about what blood sugar excursions do, so as you know, once your blood sugar or glucose starts to get up a little bit high, it becomes problematic. It's a bit of a naughty molecule that likes to stick itself to proteins, and we're all very used to hearing about HbA1c and those sorts of things when we're talking about diabetics and how it's attaching to the protein molecule in the blood and affects oxygen carrying capacity and that sort of thing. But it doesn't only just stick itself to proteins in the blood, it sticks itself to proteins in your nerves and in your tendons and in your ligaments, and creates havoc in all those places as well. So if you're not getting those blood sugar excursions happening, then you're also minimizing those sort of responses. And we know that blood sugar excursion, it affects the mitochondria in the neuron. It affects microglial activity and activation. So again, immune system responses. And there's all sorts of different things that potentially that glucose excursion is doing as well. And we often forget that, that when something like that glucose molecule attaches to something, one of the proteins in the cartilage, for example, that produces things called AGEs, so advanced glycation end products, and they trigger enzymes which degrade cartilage. So for a long time, we've really focused on something like arthritis being a very much a wear and tear problem of a joint, and I'm sure that's got something to do with the problem. But if you've got wild glucose excursions or high glucose levels all the time, that's also degrading your cartilage in your joint. And we see in trials where if you reduce the sugar load, people's arthritis pain improves. Well, you haven't improved necessarily the prettiness of the x-ray that you're taking of that person, but if you're reducing the amount of these enzymes and the inflammatory responses that are being produced in the joint, well, the person then experiences less pain. So this, just reducing glucose in and of itself is potentially a mechanism by which that you're going to improve pain. And when you reduce that glucose excursion, going along with that is the fact that then you're going to have reduced insulin load and insulin signaling. And so if the person's losing weight, associated with this, well, we know that, adipose tissue drives inflammatory processes and things. So there's a sort of win-win-wins in all different areas when you start to look at what's going on. And if you're then providing what we call a well-formulated ketogenic diet, where you're actually putting all the good nutrients in as well and supplying the nervous system with the substrate that it needs to actually recover, then there's a lot of potential mechanisms that are going to hopefully improve the person's pain. And I think part of pain education these days is really making sure the person understands the potential benefits, because we know from the research just around pain education itself is that if you can help the person understand their pain and understand what's going on in the systems, then they're more likely to get a good outcome. So that needs to then be included in the nutritional advice that we give people. You need to give them a really solid biological reason why doing this diet is going to do this, 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 and this in your system, which is really going to help your pain. So they walk away with some solid things going into their safety bucket rather than going into their threat bucket. Because if you think about their diet at the moment, often a lot of diet inadvertently is going into people's threat side of the evaluation. I feel crappy, so I'm eating bad food, I'm putting on weight. They're all negative things that are adding to that overall load of your brain going, yeah, things aren't going great here. Protection's required. Whereas if you can clean up somebody's diet and get them changing things in a way that's empowering them, and they start to feel good about the fact that they're making some positive changes to their diet and they're losing a little bit of weight and all that sort of stuff might go along with that, then all of a sudden you're helping tip those scales over onto the side of safety and again helping to decrease those protective mechanisms.
And not only that, I'm trying to mute Troy. I'm trying to figure out how to mute his mic over there. But I think a lot of this is a factor, and I would also argue along the lines of what you're talking about is on a ketogenic diet, we're seeing a lot of people's anxiety, stress, immune, their tension level getting better, and that ties back into what Tro was talking about of how much back pain is emotionally, people going through stress, divorce, horrible life experiences, and all of a sudden the pain, they have this perceived pain that's higher than someone else who's maybe has a positive attitude, that has a, that's an athlete that wants to get back to train, to play again, and how some people can recover so much quicker than others.
Yeah, and I wonder, you mentioned talking about like the how to get rid of that, the person who does better in pain trials who's just adopting a healthier lifestyle. So how did you accommodate these things, and how did you obviously, as Brian said, there's a big deal, there's a mental component, being in some sort of program or some intervention that can help your pain. How do you handle this when you're thinking about setting up your clinical trial?
And that was something we sort of pondered on quite a bit, because, you look at the criticisms against dietary trials, and it's always, the diet's then compared to the standard, Western sort of diet. And so any diet is going to look better, regardless of what it is, if you're pulling the rubbish out of people's diet. And so the approach that we decided to take with this was that we did a 3-week run-in for everybody first. And that 3-week run-in period, we removed all of the ultra-processed food from the people's diet. So we didn't say anything about carbohydrates or anything like that. It was just, we used the NOVA classification system. I'm not sure if you've seen that, but it's just like a 4-category classification. And the last category is the red category, which is just all your ultra-processed food. And so we got everybody removing those so that everybody's starting from a good diet at the starting point. And then at the 3-week mark, we then randomized people to either keep doing that diet or to then go low carb keto as well, so that we could sort of compare the two. And I think that was sort of probably an important thing to do, so that you can say, okay, well, we're actually comparing 2 good diets here. And I guess one of the things that came out of that, I would have loved, the keto diet to have been way, way superior to just pulling the ultra processed food out. But that's not the way it actually turned out. Like we're just removing the ultra processed food from people's diet got them some part of the way there. So they had a significant improvement in their pain outcomes as well. So the improvement for the ketogenic group numerically was a bit larger, but there wasn't a significant difference between the groups. So I think that's an important take-home message as clinicians as well, that, if you don't want to go down the whole rabbit hole of trying to get somebody to, reduce their carbohydrates and all the rest of it, if you can just get them to pull the ultra-processed food out of their diet, that's a great starting point from a pain management perspective.
Did they make ketones? I'm just curious, did the removing the ultra-processed?
No,
they no ketones?
No, but I guess, there was sort of some interesting things that came out of that, in that, so the group that just removed the ultra processed food, they did improve their quality of life scores and they did improve their pain outcomes. But the ketogenic diet group, they also lost significant weight, improved their depression and anxiety scores, and reduced their inflammatory markers. So those other things didn't happen with just the ultra processed food. But if you look at that ultra processed food group, I can't quite remember the numbers, but they started at 300 odd grams of carbohydrate when we tested them pre-starting the intervention. And they got down to 150 or 160 grams of carbohydrate because the ultra-processed food that you're pulling out is generally processed carbohydrate, rubbishy food. So just because they pulled that out and just started eating real food again, they dramatically dropped their carbohydrate, even though it wasn't to what we would call a low carbohydrate diet. So when we go back to thinking about the mechanisms that we talked about earlier, just reducing the carbohydrate load and managing that a little bit better is probably going to get some benefits from pain management. So even though they didn't go full on keto, they did get a good outcome. But I think it was nice to be able to say that the keto group had these other outcomes that were great as well. And it was funny. So at the end of the trial, at the 12-week mark, we did tell everybody that wasn't on the ketogenic diet, what the other group had done, and most of them went and tried it anyway, and a few of them did really quite well once they switched to keto, which is sort of a pity that we didn't capture all of that. But I think we need to really push the idea of good quality whole food for people with chronic pain. And then if you can sort of get them walking along the road a little bit with you there, then you can start to say, hey, actually, if we played around with your carbohydrates a bit, that's another thing that we could do that really might improve your pain. And the reasons are all those things that we talked about before. And so you're educating them and sort of walking them into that idea.
I think it's kind of critical here that we now have interventional data showing that we can reverse diabetes, or at least put it into remission. We have interventional data showing that making positive dietary changes will increase your metabolism. Mental health is something that's been shown. Another Australian researcher, I think, what's her name? Professor Jack, maybe? I don't know what her name is. She did the first interventional trial, the SMILES trial, which looked at making a real food diet for depression, and she showed that depression and anxiety scores actually improve. And now we have, two studies, one study showing low carb diets preferentially compared to low fat diets improve knee arthritis, and now a real food diet at the least showing that it improves chronic pain and potentially some inflammatory and other mental health outcomes. This is fantastic. I mean, you should be so proud of yourself that you're pushing the barrier.
Yeah, this is huge. It's a huge, it's a huge, chronic pain is one of my least favorite things to treat. It's very, very challenging. And it's because it's such a complex problem with stress and depression, anxiety, and it seems like they're interrelated in a way where if you're in chronic pain, I can see why you're grumpy and don't want to, enjoy life very much because everything hurts. And then also the more depressed people are before they get injured, the worse their pain outcomes seem to be. And it seems there's a lot with, dopamine response and drug addiction and all these kind of things. And so it's a hard thing stepping back as a primary. What would you tell, like because the problem is you're seeing people after they've been treated for chronic pain and they may be on opiates. By the way, anyone listening, the number one cause of death in the US right now from the age 18 to 49 is fentanyl overdose. Right. So we have a huge problem with opiate addiction. And so us docs, we say, okay, you hurt your back, you have sciatica and you're miserable. Let's throw you on some anti-inflammatories. That's not working. Let's throw you on some prednisone. Okay, let's control your pain with an opiate. And we go down this pathway. And so that would be my first question to you is like, how can doctors manage this acute pain better so that we don't set up these problems for you to help to reverse the ship?
Yeah, and I think that comes back to that other area of research in the neuroscience pain education sphere is very much educating people to understand that chronic pain doesn't necessarily give you a good indication of what's going on at the tissues, and really trying to help people understand that, because that's one of the big problems that patients don't have, because they're also structure focused, just like some of the doctors are. They think somebody needs to fix my problem for me, when we really need to be starting that education right back in the doctor's surgery, saying, there's lots of things that are going into this problem. Yeah, the structure's got a bit to do with it. Yeah, your scan doesn't look that pretty, but there's all these other things going on for you as well. Your diet's not great. Your weight's up a little bit. You've got stress at home. All these things are adding to the problem. How about we sort of try and look at all of these things and helping the person to understand it? Because if they don't have an understanding of why they're doing something, then we find that sort of education, it doesn't work. So you've really got to sell it to the person and have them believing that there's good reasons why you're going to do this stuff, because there's all sorts of great research out there looking at how just what somebody thinks can change their actual physiology. I don't know, have you seen any of the research from Crum and some of those people that look at how and particularly in the nutrition space, I found this fascinating. They do things like that, have two different types of milkshakes that they're giving to people, exactly the same milkshake, but once they're telling them, oh, this is this decadent milkshake that's full of fat and blah 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 and all this stuff, and the other one's like this superfood milkshake, exactly the same milkshake, and then they'd measure their hormonal responses, and their ghrelin responses were different between the two, even though it was exactly the same milkshake, because the person believed one was virtuous and a good thing to be eating, and believed the other one was naughty and bad for them. And even things like, they did another experiment with workers in a hotel situation. So these were the workers that were the cleaners. And so, the cleaners were sort of, they were talking to them about, their health and fitness and all the rest of it. And so one group, they told them that, what they were doing within their job, they were meeting all the exercise requirements. You're doing awesome. Like you're exceeding all of the recommendations. You guys work really hard. Your exercise capacity is great, doing all this stuff. and then measured them compared to the group that just got told no, they weren't sort of meeting the requirements. And the other group lost weight and all the rest of it, even though they didn't change anything. They weren't doing any more exercise. So what our brain thinks is going on has such a powerful outflow into our physiology. And so part of, as you know, our job, I think, as practitioners is to really, you know, sell this to people and help them understand the good things that they're doing and really putting it into the safety bucket for them. And so that's going to help them with their physiological outcomes.
Yeah, it's a huge, the mental the focus is such a huge thing. And, you know, there's a study that they did with mice, even that one mouse would control the treadmill. They couldn't see each other. So if this one chose to run, the other one would have to run. And the one who had to run, but it didn't choose to, had worse physiologic outcomes, increased stress levels, crazy, all these things, because it was like, oh, I got to go to the gym. And instead, those people want to go and they're excited and they can't wait to, you know,
get better
do something.
outcomes.
Yeah, it's really amazing. The power of the brain is unbelievable. Sorry, Troy, go ahead, man.
No, guys, this has been just absolutely.
Wait, Troy, you can't just end it. I have another question. So when I was at med school, one of the surgeons, before he took out someone's appendix or did a hernia repair, he would do a local numbing of that area before he did surgery. And it was while the person was under. They would put him under. He would numb up the area, and all the other surgeons were laughing like, this guy's wasting so much time. But his outcomes were better. And there's subsequent studies that have shown if you block that that pain synapse early, that you're going to have better outcomes from chronic. So that being said, I think the problem is that we're overly aggressive on treating the pain response when someone has an acute injury, where we think that putting them on an opiate, for instance, I don't think that's going to block the long-term pain sensation, and it may make it worse because people feel that they have to have this to survive now.
Yeah.
So I think that's the problem, is when I have someone who comes to me and they've been on opiates for the last 15 years, how do we manage that?
Yeah, that's a really hard one. And I guess, you know, the people that we see are all in that category because we only get the sort of the tail end of chronic pain patients in our practice, and they're all on, you know, by the time they come and see us, you know, everybody else has sort of thrown up their hands and given up and said, okay, now I do pain management. And really that should be sort of right back at the start, rather than once everything else has sort of had to go and failed. But yeah, the medication thing is hard because you can't just quickly take somebody off medication, not only from the physical response, but also the brain's going, oh, hang on, what happened? You know, oh, that's dangerous. And so regardless of nothing changing physically, that's going to increase their pain experience because the brain has now perceived a threat and protection's required. So we sort of try and get people educated first and get them sort of, I change diet and stuff first potentially, and then start to get them talking about, let's just start sneaking down the medication. And it's a little bit like with the movement approaches, we try and sort of sneak up in underneath the radar of the car alarm. We're doing the same thing with medication, just, you know, just little tiny decreases in it so the brain doesn't really notice what's going on. But as you say, like when you get people in that situation, it's really hard to work with people, and particularly in the, you know, in the few minutes that you guys have got in general practice to try and deal with the myriad of things. I mean, we've got the luxury of spending an hour with the person every week working through all this sort of stuff. So I guess one of the things that I'd say to, you know, the professionals working sort of more at the coalface is to say, well, use those resources you've got with pain management if you've got those sort of programs available, and get people into that early rather than it being the last resort when everything else has failed.
Yeah, we've done it's a tragedy. Tro, you know, that's the same story. Like, people are seeing there's pain specialists once a month. They see them, they get their pain meds refilled, prescription. Next month, they're saying they're charging them for drug testing and all this other stuff. And it's a never ending cycle. And so many people listening are in this situation where it's really hard because, you know, it's a dependence and you're stuck in the system. You can't get out of it.
Right. It's the path of least resistance for everyone to keep patients on those drugs. That's the problem, right? It is the path of least resistance, right? For the patient, right? For the doctor, right? And that is the problem, right? I think that's the problem. We've set up a system where the status quo is acceptable, right? If that doctor got paid less and less each script you refilled, you better believe you probably would have done something different. And that's the worst part of this. Sometimes docs, they want to be compassionate. I understand, right? They want to be like, you don't want to see somebody in pain, right? But at some point we have to evaluate, what is the harm I'm going to cause? right?
But at the same token, when the DEA came down strong on doctors, a lot of doctors said, okay, I'm not prescribing this anymore. Well, this patient's been on it for 10 years now. Now all of a sudden they say, I'm not writing anymore. You have to go somewhere else, and they can't find a doctor, and it's a disaster. It's really
and imagine what
tragic.
that does to them from a threat and safety bucket perspective. Like that's going to just scream threat to their brain. Of course, it's going to make the problem, just compound the problem. So yeah, it's not the answer just to stop the medication, suddenly either.
And is your clinic unique, or are there other clinics like yours doing the same types of techniques? I don't know of anyone here in the US doing this. That's the way I'm really asking.
No, it probably is fairly unique. It just, so as I said, I work with a psychologist and we're great mates, and it's just been this process of us developing this approach. There is a couple of pain specialists that sort of refer directly to us, and that's where we tend to get most of our referrals from, whereas we'd like to see it coming from the GPs a little bit more to be getting people earlier and educating them earlier rather than when it's right down the end of the line. But yeah, there's not a lot of pain management centered like ours. There's quite a lot of big public ones, but they still tend to be a lot in the old model of pain management. So the old school of pain management would say, okay, look, we've tried everything. All we're going to do now is, put you as an inpatient for a couple of weeks, play around with your meds and teach you to suck it up. And, that's not really good enough now when we look at the new neuroscience research that's out there that says, no, hang on, what's happened is this person's system has become so sensitized now based on what's been thrown at it. It's neuroplastic to its way into this problem. We just need to change what we're throwing at it. And there's every chance that we can get them back to a less painful state. And so that new idea, the cowboy's idea of what's going on, that's slowly starting to infiltrate, but it takes so long to get that from research into, as into clinical practice. It takes a couple of decades sometimes to do that.
Yeah, it's just going to be grassroots. So thank you for your work. This is amazing. Thank you so much for your time and for educating us on this area. It's critically important. People just don't realize what it, especially now with COVID, increased stress levels, all these things, the impact of, just saying, okay, here's an opiate, here you go on your way. And, it's like Tro's saying, there's multiple layers of problems. So, what you're doing is actually that will help save the system, because the system cannot function at this level that we're at.
Can I tell you one last thing? I'm so happy to have you here. Thank you for educating us. Thank you for doing, I don't think people understand how many years it probably took and what level of advocacy it took to get your trial up and get your trial done and get your trial published. And I don't think, people, I bottom line is I admire your work. I admire everything you're doing. And we're so happy to have colleagues like you throughout the world, finding truth and setting up great trials and doing what you're doing. We have one Patreon supporter, one of the people that kind of donates and supports us and is joining us here today. Bob says, we're just fantastic podcast, and coming from somebody who's had several ruptured discs, he can anecdotally report that it just disappeared after doing a keto. How often do we all hear that? And I don't think we understand, and maybe we take it for granted how magic that is. So I just thank you.
And you give us credibility, because this is what you do. This is your focus. And we see this and we feel like kind of like what you're saying is you feel like it's the magic pill, like that movie, The Magic Pill, where you think, yeah, your pain, okay, do keto. Oh, your mood, okay, let's try keto. Oh, your sugar's out of control, your back hurts. And it's amazing because you look at it and we're seeing this anecdotally, we're seeing it in our practice, but to hear you using it and understanding it, and we have psychiatrists using it, and it's helping people with schizophrenia and all these, when you start looking at how these neurotransmitters work and what medicines we're using for these conditions. I have to ask one last question since Tro's doing something. Do you think the level of ketones makes a difference? Do you think if people are at a higher level of ketosis, they're going to do better than people at a lower level of ketosis?
That was my assumption going into this, that higher ketone levels would be important. And so we measured the ketone levels of people throughout the trial. They're just with finger pricks, but their ketone levels didn't get up as high as what I was hoping they would. And I think part of the problem was that we measured the ketones first thing in the morning, because as part of the protocol we had to have like a standard time when they were going to measure their ketones, and it turns out first thing in the morning is not the best time to measure. If we had them measured mid-afternoon, it probably would have looked a whole heap better. But the average ketone level was only like 0.3 or 0.4 or something like that. So it wasn't high. In my mind, I'm thinking, oh, we're going to have to get these people up to, 1.5 because the ketones are going to do all these magical things. Which is when I then started thinking, okay, well, ketones have got something to do with this, and the mechanisms around that are important, but just reducing the glucose is important in this as well. There's lots of factors potentially.
And just taking out the processed food, that effect, because a lot of people think they could just eat the same diet and take some exogenous ketones and everything's gonna be better, but it's more complicated than that.
It is more complicated than that. And again, that's something that hasn't been researched at all, is looking at how exogenous ketones might be useful in pain management. And I suspect that might be something that we really need to look at, because there is, just the same as we've got, populations that we use exogenous ketones with because they can't do a diet. When we think about like Alzheimer's and those sort of patient populations, well, sometimes you get, chronic pain populations that just don't have the space in the head to deal with dietary change at the time. So I wonder, what would exogenous ketones do in that situation? And that's a great trial for somebody to do, because I suspect there's probably a group that would be really helpful for.
Amazing stuff. Thank you so much again for joining us, Tro. You want to close this, man?
No, thank you so much. This is great work. Thank you for joining us and educating us. All I can say is we think you're a superstar. So thanks for coming on board, waking up at 5 a.m. to hang out with, me and Brian.